Questions? Any questions from the audience? No questions. I would like to call upon the next speaker, Dr. VBN, one of the director of High Care Wounds, and one of the experienced diabetic foot surgeon in Chennai. The topic is Cellular, will it make skin grafting obsolete?
Not this one.
Sir will tell now.
Next one. Next one. Not this one. Yes. Fourth one. Not this one. Just the one which says Cellular. Yeah. Good evening, and the fag end of the day when everybody is fagged out. I think, let me see how I can make this interesting. As you know that all through the day we found that we are looking at various different aspects in managing wounds, and you also would have noticed that as we grow older and become more experienced, there's a tendency to become less and less aggressive. And Cellular, I'm going to talk to you about a new technology which has come, which is a very interesting thing. And all I'm trying to do is to see, to try to see as a plastic surgeon how we have metamorphosized or try to change from being very aggressive to use this latest technology. I have divided this into three parts. One is to see how a plastic surgeon looks at wounds. It may not be very relevant to some of the people here because there are truly very massive wounds, but just to make the presentation complete, I'm going to give some examples. Second part of the presentation is briefly on the amount of research which has gone into development of this, which is very interesting, which I'm going to very shortly talk about. And thirdly, of course, I'm just going to give you some examples of what this actually does. Now, Cellular, will it make the skin grafting obsolete? That I think you will have to decide at the end of the procedure or the presentation. Now, what we want to look at today is, again, wounds. You know that some of these wounds actually require skin grafting. What are the types of skin grafting available? What is the need for skin substitutes? Because we are looking at emerging technologies and emerging types of replacing skin, and of course talk about the need for epidermal replacements where this new technology will be talked about. Now, skin is a very important organ, and you can see that it's got several functions, and of which I think we're going to talk about two things. One, talk about protection and looks, because I think these are two things which I am interested in. Looks, as you know, is very important, and again, coming to technology, a lot of, I think 20 years ago, where there's a lot of emphasis on doing surgical procedures, but now there's a lot of technological things to see how we can increase the looks of these patients. As you can see here, a lot of advertisements on technology to revitalize the skin. As again, you see the paradigm shift, people thinking about doing everything possible, right? Let's face it, life is too short. Use of technology here. And ideally, if you can replace skin, you can change your aging process, okay, and then get a good skin so that you get a good looking skin. Again, the emphasis is on non-invasive procedure. I think 20 years ago, we would have actually done a facelift on this patient. Sorry. But as you can see here, this lady has had completely radiofrequency and ultrasound therapy, and you can see how beautifully she has looked almost 10 years younger. These are some of the technologies. What happens here is, you work from within and the skin looks better. Protection, again, you don't have to say. Skin is the most important thing which protects your body, and depending on the depth of the burn, which is a common example which we deal with, where the protection is lost, depending on the degree of the burn, you actually do the treatment using skin or skin supplements. Again, coming to this what we need to discuss, the spectrum of the wounds, not going to the details about the causes, going to give you the size and complexity, time and place. Just to give an example, as you see here, this is a very simple wound. As you look at it, this patient has just had a sutured wound, totally, this was missed, fractures missed, just to find out in about 4 days' time, completely broken down, and then you can see that the bones are exposed. Is a very, very major problem. So this is how we deal with it. We use the local skin to heal the wound, and then there's a bone defect. We use the same fibula from here. Can you see? This is a defect. We use this fibula, turned it around, and then we bridged it. So this patient is completely so such a massive complex thing has been reconstructed. Another example where you need a lot of skin. Now coming to areas where you just need epidermals, right? This is one of the common things which we face. As you can see here, this patient has got loss of sensation. He has been walking on a pilgrimage, and he has come with this loss of skin just on the plantar area. There's an acute wound, and very commonly you see a lot of patients, diabetics with loss of sensation, having chronic wounds. So this is a place where you probably don't need very massive things. You need to think about using skin grafts, and if you can make it very simple, it will be very useful. And if you can get a sensate skin like here, as you can see, this patient has had this procedure. You brought a skin which has got sensation, and then if you use a skin which has got sensation, then the patient will have no ulceration again. So if you put a large skin which has got no sensation, there's a chances of ulceration. But if you can just put a very thin skin on a sensate area which is underneath, right? If you just put an epidermis on a loss of skin, then actually the sensation will be protected. So the more complex skin you put in, your sensation will be lost. If you put thinner and thinner skin, then your sensation can be retained. So what are the things we do? So strategies of wound closure, I'm not going into the detail. We have non-surgical methods, skin grafting, which we'll talk about briefly, non-cellular matrix, combination matrix and culture, and the topic today is going to be epidermal cell culture to replace epidermis alone. Now there are a lot of skin substitutes available which can be used. Some of them are designed based on some matrices underneath to design them and to get whatever you want. Others are targeted at chronic wounds. Now again, going back to the same thing I showed you before, we have various different types of wounds. They may all require skin grafting. So if you can make sure that the skin grafting is as simple as possible, looking at the donor site as well, then that's the solution which you can get. As you can see here, this patient, you can think of two things. You can either offload, you can put a graft and then offload. So the question is, how quickly can you get this done? And without a surgical procedure, not without a major surgical procedure, without hospitalization, without getting a donor site, if you can get all those things in one go, then it's a possibility. Another example. So when you talk about skin graft, there are two things you need to worry about. Donor site. Don't forget that donor site, when you remove the skin, there is always the donor site which can be problematic, however careful you are, and you can't ignore that. The second thing is, if you can do these things as an outpatient, without the patient getting an anesthesia, without patient getting admitted, that's another thing you need to look at. So these are the two things which you can look at and improve if possible. So again, the function of the skin depends upon which layer the skin is included, okay? And once the skin can be grafted, provided the wound is ready for grafting. So two things are very important. You need to have a bed which is clear and ready for accepting a skin graft, and then depending on how much skin you want, you can take. So what are the different methods available for taking different skin grafts? We know that there is a split thickness graft and the full thickness graft, but what we want to talk today is to see if we can take much thinner grafts, like as you can see here, just a small epidermal graft, or punch grafts as you can see here, or miniature punch grafts, or you can have cultured epithelial grafts. And what we need to talk today is the suction blister epidermal grafting. So these are the various things available. And depending on the technique, you can harvest them and do that. So this again to tell you what happens to the donor site. However thin and however good you take, there is a possibility of crusting, hyperpigmentation and keloid formation or hypertrophy, and long-term problems with this donor site. So what is that you can do if you can avoid skin grafting, anesthesia? So if you can avoid all these things, right? If you can avoid an anesthesia, the patient can be done as an outpatient. You don't have to refer to a surgeon. Patient has excellent donor site, and then the donor site heals well. So if these can be taken care of, you also have to remember that when you take a skin graft, the healing happens from the sides. So if you can make sure that the healing happens from the depth rather than the sides, then the healing will be much faster. Now this is just to give you the evolution of the blister epidermal harvesting, which is what the cellulotome is based upon. You'll find that most of them have no pain, right? And then the donor site is much better. You can harvest the epidermis and also some more cells, melanocytes and other cells. And this is the study they did, okay? Can you see? Just to show how efficient the machine has been developed. They're based on a lot of research. You need to know that the cells which are taken are viable, whether we have enough epidermis and dermal junction, whether the taken skin graft is actually growing, possible to grow, and whether it produces secreting growth factors. So this is just to tell you the number of research has been done to study. Numerous small grafts have been taken and studied, and they found that actually the small grafts which are taken are actually viable, okay? And this is again to show that if you take multiple grafts, they were uniformly viable. And you can take, the blister actually shows how much to take. Essential skin can be used to take. This is how a blister is formed, and the blister actually has not only the epidermis but also some basal keratinocytes also. Okay, so what happens in the blister epidermal harvesting is you form a small blister, and this epidermis is pulled up, and then you cut it out, and then you use this skin alone. Okay, so that's the graft. And we found that the graft actually survives, the edges survive, the cells survive, even the melanocytes survive. So if all these things can survive with a blister, and if you are able to transfer all these things and again get the benefit of all these cells, then you have a possibility of developing a system. So these blisters which have been harvested actually grow from the sides, and they can bridge. Okay. So this again to show that not only the keratinocytes but also some of the melanocytes are there, and that can be used. So this is again to show the viable cells. So in summary, what it does is the reepithelialization wound is because it's a problem, we need to look at other aspects, and reepithelialization of the wound reduces the risk of infection by restoring the protective function of the barrier function. So what does this epidermal harvest mean? So donor site sparing epidermal grafting system. So what we're going to talk to you today is ability to remove the epidermal grafting system, and there's no need for anesthesia, and it can be done as a outpatients. So this is the machine. I'm sure you'll all see this later in the stalls. Basically, it has a small device here, and this is actually put onto the patient, and there's a small suction, and this is again put in. So the small holes, they produce blisters, and this is very cleverly designed in such a way that the blisters are cut, and the epidermal cells are transferred from this area into the graft wound. So how is it done? So what it does is this small piece of thing is kept on the patient's area where you want to take the skin, and then there's a small sticky substance there, a tape, and then it produces small blisters, and then there's a blade which cuts the blisters, and the small epidermal cells which are there in the blister is actually stuck to this, and this can be used to the for healing. So this is what the procedure is done like this. You select the donor site, you put this apparatus there on top of it. The apparatus inside has got this small meshed or it's called a graft acquisition thing, and then it produces a blister there, and you remove that. When you cut it out, this is how it looks, and this is the donor side. This is the donor side. As you can see, small blisters, they just disappear within 2 weeks. They're completely gone. Okay. This again, sorry, it's the same thing. So 2 things we found out. One is you have the ability to, you have the technology to harvest just the epidermal cells. It has got the epidermal cells plus the keratinocytes and also the melanocytes, and it takes a representative sample of the epidermis, and the donor site is not painful. It heals very well, and you can transfer these epidermal cells to areas where you want to graft them. So this example of a patient where he's got this area of granulation tissue ready to actually accept a skin graft. Normally you would have taken a small piece of skin from the thigh or somewhere and you put it in, it will heal very fast. Okay. If you leave it alone, it will take a few weeks to heal, but you want primary epidermal union. So the answer for these would have been skin grafting, which would have left a large raw area. But this new system, what you can do is, the epidermis is taken with the help of this, what is called a cellulome, and then they are applied here, and you can see in about 4 to 6 weeks it actually heals very well. Another example of this patient, okay, as you can see, this is a patient with rheumatoid arthritis. We are extremely worried about taking skin graft in these patients because the donor sites will not heal. They may be on steroids, skin may be very thin, and if you take skin from the thigh or other areas, the donor site is a very big problem. They don't heal. So you may actually have another area which is not healing on the thigh and the donor site, and this may heal. So to avoid that, you need a technology, and this technology I'm sure is an extremely useful thing, where the donor site will completely heal, and this area is now, as you can see, this is a very well prepared bed, just waiting for the epidermis to come, and this is about healed in about 6 weeks time, and the donor site is healed. Another example with a diabetic, okay, large ulcer which is nicely prepared. You leave alone, it will actually heal by granulation tissue and scarring. Good example for an epidermal graft. As you can see here, in about 6 weeks time it completely heals. Another example, as you can see here, large ulcer. Look at the quality of the skin, is very bad, but the area, the recipient side is extremely well prepared, ready to accept a graft, and it's nice and plain in one plane, and this will do extremely well with the help of the cellulome epidermal grafting. So you can see that in about 4 to 6 weeks it beautifully heals. It actually heals by epithelialization rather than scarring. Another example, as you can see here, the patient has got this wound. Okay, if you leave it to heal by itself, this will actually scar. The scar will contract. It will actually cause contraction of this little toe, and it will actually either get pulled to the side or pulled to the top, and it will cause problems. And you don't want to have a large donor area which will cause trouble. Another good example for the use of the cellulome, and as you can see that this patient slowly heals. This is the transparent sheet where the epidermal cells are there. This is the donor site. As you can see, this will heal in about 2 to 3 weeks, and this is where it starts healing. Initially, actually, you will not see those cells, but if you look closely, you can see the small cells there. This is already healed, and you can see this slowly it's healing. In about 4 to 6 weeks, is completely healed. 5th week is completely healed. So it's a good tool to have in mind when you're looking at smaller wounds, where you don't want to have they don't have to be hospitalized. You don't have to give them an anesthesia, and you're worried about the donor site. This is a good option. So the indications are, it's used as a epidermal harvesting system to minimize skin grafting problems in the donor sites, and is very useful. There are basically no contraindications. Thank you very much.
Good presentation, sir.
Thank you.
So can you tell one reason which is against this cellulome and for our older technique?
See, I think my experience is that you have to be extremely careful about selection of the patients. the indications of a graft remains the same. You need to have a well-prepared bed which is ready to accept a graft. I can't see any contraindications. The only things I would be very careful is if the bed is not plain, because you're taking this on a sheet of an adhesive, and the adhesive you take which has got the epidermal cells has to actually stick to the wound. And if the recipient site is not plain, or if it has got some undulations, and if the sheet which you're taking where the cells are there, if they don't come in contact with the recipient site, then these cells will actually die, which will happen even to your skin graft. If you take a regular skin graft and then you put it on this sort of a curved or a concave wound, and then if you don't, what we call it as, if it doesn't stick to that wound bed properly, it will also dry. So here the chances are much higher. So I would think you have to be very careful with the selection of the wounds, and more importantly the contour of the wounds. So when you place the epithelial cells, you have to make sure that they actually stick to the wound. Otherwise, you lose them.
Thank you, sir, for enlightening us latest the developments.
Pardon? Cost, I think we'll have to speak to them.
Dr. John, what is your experience with Cellutome?
The Cellutome for us, we've used several times. I agree very much the harvest site works much better to harvest from the thigh than to try to do from the calf. If you do from the calf, you don't get the epidermal blistering as quickly. It takes too long. But we have used just on a handful of patients, less than 10, and I have got about a 50% healing rate so far with those, which is, whenever we have something new, we always throw the hardest patients to something new. So to get 50% of those folks, I've been very happy with.
So it will take more time for, newer improvements have to take place.
Well, and I think it's more us getting to know patient selection, as was pointed out by the speaker, that we need to know which are the right wounds to use this for, and also realizing that sometimes we need to be even a little more patient, because I think at first I didn't recognize, because you can't see the graft there. We keep debriding, or we're doing something, we give up on it, whereas we probably could have just waited and those other patients, and they would have healed because the cells were actually there. So I think the speaker pointed that out well. You need to really wait 6 weeks and see what you get.
That happens even in a regular skin graft.
Yeah.
Sometimes you just lose the epidermis, and then you take the graft and you find, my God, everything is gone.
Yeah.
And then we say what is called the vanishing skin graft syndrome. So you just think that it's gone. But the key is that the bed will be dry. Yes. If your regular skin graft actually vanishes because of, let's say, poor bed or something like that, then it becomes wet. But whereas here, if the epidermal cells are there, and even if the the epidermis goes off, the wound actually will be very dry. And then the epidermal cells or whatever, they slowly come up. They just heal. So so I'm sure it's the same thing happens here. So you just have to be patient and just not think that it is gone.
And it's very, very easy to use. Not technical-wise, it's very simple. The patients are concerned at first, but there's really nothing to it. So.
Now the question to the topic: will it make the skin graft obsolete?
Yeah, I don't know. It's limitation for the size, right? About a 5 square centimeter area, but I guess they have bigger cartridges, or you could do multiple. It would be nice if it made that obsolete. It would be good.
Yes, sir. How about the use of suction blisters? The ordinary suction apparatus, we use the theaters. Can you take blisters with the suction apparatus?
If you look at the entire research, it's been very extensively researched. The thing is, you cannot make it, the blister should not become very thin. The surface area should not be larger. It's very important that you take the right amount of, if it is this doesn't produce suction alone, it actually causes a blister. It's just not suction. It actually, in a controlled way, it heats up the system inside the thing and causes a controlled blister. Now, if you say the same thing, in burns, in an acute burn, you'll find that in a superficial burn, there's a blister. But that blister is dead. Because
actually, basically, I'm a dermatologist surgeon. We use the suction blisters for vitiligo grafts.
Correct.
Just a cosmetic camouflage. So that's why I want to know whether that can be applied here.
This is
it will be very cheap.
This is something similar.
Apparatus can be used. Can it be tried or not? Thank you.
totally a different question. I have a patient, diabetic patient with recurrent keloid formation, and beneath that he got a recurrent abscess formation, scarring. How to manage the case?
It's a very difficult question. See, what we do see all these patients, a lot of these patients who come with this recurrent infection is because of the hair inside. You'll find that a lot of hair which gets infected and things like that. We have most of the time tried to clean them and keep it under control. On occasions we have actually tried to exercise it because sometimes it's so difficult that they can't manage. So in those situations we excise the entire thing, put graft, and then we use the external beam radiation which is available. We have very good, very targeted radiation which can be given, and they actually it's an answer. We have not done many patients, but definitely about 1 or 2 patients who had severe, as you said, severe recurrent infections, where actually there's a hair in between the holes and then they get infected. So we talk to them very frankly, tell them it may not work, but we have done that. And then you'll find that in those situations they will get keloid, but it's interesting to see that they'll actually get keloids in the sides. The center of the area where you put a skin graft, they are okay. The side will actually get the recurrent keloids, which you can actually give radiation. But you have to warn them that the graft take will be less. They will have loss of graft, which will again make them prone for a scar formation. So it is difficult.
Any more questions? Okay. Thank you, sir.
Thank you.